Hello, everyone. I'm Dr. Monica Mallampalli, CEO of the Alliance of Sleep Apnea Partners. ASAP is a nonprofit advocacy organization very much dedicated to being patient-oriented and patient-focused. Our mission is to promote and advocate for screening, diagnosis, treatment, and management for optimal health of those who suffer from sleep apnea. Welcome to the Breathing Room, an ongoing virtual series to discuss timely topics, whether it is the latest science, practice, or policy related to sleep apnea. In today's episode, we'll be discussing the obesity and obstructive sleep apnea connection with our two panelists. We will touch upon some general points related to obesity and OSA, what we can learn from the obesity community, the approval of a new medication to treat obesity and sleep apnea. What does that mean for physicians and patients, and some policy-related takeaways. Let me now introduce you to our panelists. We have Dr. Chris Schmickl. He's an assistant professor and the director of the Advanced Care and Electrostimulation for Sleep Apnea program in the Sleep Clinic at UC San Diego. As a sleep medicine physician, he frequently sees the transformative effects of therapy for obstructive sleep apnea, but also how many patients struggle to tolerate current treatment options. Thus, as a physician scientist, Dr. Schmickl's primary goal is to develop novel and personalized treatments for patients with OSA. To paraphrase Abraham Lincoln, Dr. Schmickl firmly believes that successful treatments of patients need to be developed with input by patients to ensure they truly help improve the lives for those patients. Our second panelist is Dr. Tracy Zvenyach. She's the Director of Policy Strategy and Alliances at the Obesity Action Coalition, or OAC. In this role, she provides leadership in the development and implementation of policy priorities and strategies for OAC, and represents OAC in alliances and coalition efforts to advance obesity care. She also serves as an adjunct assistant professor at Georgetown University, where she teaches healthcare policy and advocacy to graduate level students. In her previous roles, Dr. Zvenyach led obesity public policy and advocacy efforts in industry and worked in the U.S. Senate for years on topics ranging from healthcare, women's policy, workforce, disaster response, and judiciary policy. Two legislative highlights include her work on provisions, including the Affordable Care Act and Reauthorization of Violence Against Women Act. Her research and publications focus on health economics and policy research to address barriers in obesity care, as well as diet quality of pregnant women receiving the Women, Infants, and Children WIC supplemental food program. Dr. Zvenyach received a BS in nursing from University of Wisconsin, Eau Claire, and her MS in nursing and PhD in health policy from University of Maryland, Baltimore. She volunteers her time on the board of directors for Wisconsin Nurses Association. So welcome you both today. I'm pretty excited to have this conversation with you both on obesity and the OSA connection. Before we get started, I just want to just present our audience and viewers with some sort of background and points related to both these conditions. So approximately 54 million adults aged 30 to 70 years in the US are estimated to have obstructive sleep apnea, or OSA, and its prevalence continues to rise. Proper treatment and timely management is crucial because OSA significantly increases the risk of cardiovascular conditions and can be life-threatening for some individuals. And it's the same with obesity, as we know. Obesity is the strongest risk factor for obstructive sleep apnea for both males and females, particularly central obesity, which is the fat around the waist and neck. OSA prevalence is less in obese females compared to men, despite obesity being more prevalent in women, which I thought was a very interesting point. And also it's been found that increase in waist to hip ratio increases OSA risk in women. The risk for developing OSA increases with increasing weight, as shown in population studies. A 10% increase in weight is associated with a 6-fold increased risk of developing moderate OSA. OSA prevalence seems to grow in parallel with increasing BMI levels. In fact, since 1994, the US has seen an increase in obesity rates as well as an increase in OSA rates. In the US, approximately 69% of individuals with obesity have any form of OSA, which is mild to severe, and 32% have moderate to severe OSA. This is according to the Sleep Heart Health Study research group from 2002. So the data is a little old, but I'm sure the numbers, there has some change in probably those numbers. OSA prevalence is high in African Americans, Hispanics, and Native Americans, in part due to obesity. And like obesity, OSA is common in patients with hypertension, type 2 diabetes, and cardiovascular disease. OSA can cause weight gain, and weight gain can cause OSA, suggesting a bidirectional pathophysiological relationship. Continuous positive airway pressure, or CPAP therapy, has been the gold standard therapy for treating OSA. Although effective treatment can be achieved with CPAP therapy, poor adherence can be a barrier for many. Patients have trouble adhering to CPAP or looking for alternative therapies or interventions that can be used alone or in combination with CPAP. Weight loss can help reduce the severity of OSA and the cardiometabolic abnormalities associated with both OSA and obesity. A comprehensive weight loss program combining diet, exercise, and behavior modifications has previously been suggested. And finally, important to note, and there's a lot of research backing this, that bariatric surgery has shown decrease in BMI and AHI. AHI is the biomarker for OSA currently. And again, another point that I found interesting is that more women tend to get the bariatric surgery. Many patients continue to experience moderate to severe OSA post-surgery, even with normal BMI, due to maybe physiological factors, or anatomical factors, which are, whether inherited or acquired traits, and not related to obesity. So this sort of just lays down some of the background that I wanted to share with both of you before we get started on our discussion. And so let's continue with this connection of obesity and OSA. So Chris, I'll pose the first question to you. So in your practice and in your clinic, do you see obesity in most of your OSA patients, and sort of what has been your experience, and how many people are affected by the comorbid obesity OSA, which is frankly, this is the first time I've heard the term, which you have called COBOSA. So maybe you want to expand on that a bit more.
Sure. First of all, thank you so much for having us here today. And I think this is a really exciting forum. I think a lot of things are changing right now in the sleep medicine field now with these new very potent medications that help people achieve weight loss that is almost in the range of what we've previously seen with bariatric surgery and are generally pretty well tolerated. And so I think as sleep physicians, we are thinking a lot about right now about this comorbid obesity and sleep apnea. And yeah, I think we just recently coined this now. There has been previously that comorbid insomnia and sleep apnea as a distinct subgroup of patients with sleep apnea. But I think now that we have these potent medications, I think patients with that obesity, sleep apnea overlap are another very important subgroup because it changes how we can approach the management for these kind of patients. And so, to your question about my practice, to be honest, my practice is a little bit biased from what most other sleep physicians would see because I am specializing on patients with sleep apnea who have failed standard therapies. And so I usually see, more severe cases, patients with more severe sleep apnea, more severe symptoms and so forth. And so I think in my practice, probably 70–80% of patients probably have some overweight/obesity or so. And so oftentimes we do think about is maybe the weight something that we can go after in order to help improve their sleep apnea, either to cure it or at least improve it to a point where now other therapies like an oral appliance, which by itself may only be 50–60% improve the sleep apnea, it now becomes more effective because you have less sleep apnea to begin with. From the estimates that I've seen, I think a lot of people are looking into this right now. I think in general, we think that there's probably somewhere between 40–60% of patients with obstructive sleep apnea who have obesity. And so that, in this range, that's kind of I think what we think that obesity is contributing or contributing to sleep apnea or the amount of sleep apnea that's attributable to the obesity. And so, yeah, I think one important point is obesity is certainly very important for sleep apnea, but not for everyone. There's still plenty of patients with sleep apnea who have sleep apnea regardless of weight or in the absence of obesity.
So that's an important point to make. So OSA, again, can be, not all OSA patients are obese, but then not all obese patients are perhaps have OSA, but I think it's important to just make that distinction. Tracy, tell us more about Obesity Action Coalition and what you do there, and how often do you hear about OSA in the obese patients that your organizations comes across? Let's say again compared to diabetes or heart disease.
Thanks for having me join you today. It's a pleasure. So the Obesity Action Coalition, we are the leading national nonprofit dedicated to serving people that live with the disease of obesity. And, we serve approximately over 85,000 members today. And we focus our efforts around providing support to the community, educating the community, increasing awareness about obesity and many of its complications, with OSA being one of them. And then lastly, around advocacy. So advocacy around access to care issues. So a lot of that is policy related. And the other advocacy around weight bias and weight stigma. And, that many members of the OSA community who are also living with obesity face weight bias and stigma. One of the areas under weight bias that we talk about is people first language, around how people living with the disease are not their disease alone. So when we talk about when we talk about obesity, we say people living with obesity or people who have obesity, as kind of putting that honor and that recognition around our patient community.
No, that's such a good point. And I think something that we are very cognizant at ASAP as well, and the way we use the language. Crystal, what are the, I kind of mentioned this in my opening comments too, but and I think in your bio as well, but what was the common recommendation typically in patients who are coming in, with OSA and obesity? When suggesting, weight loss to improve OSA. I mean, bariatric surgery seemed to be the most common. I mean, this is when it's really severe in these patients. And of course, it's not that easy to lose lose weight. It's easy to tell the patient, but there's a lot of, it's very complex. And then, so again, just how do you interact with these patients, or, so if you want to expand on that. And of course, now, we'll get into a bit more about, the drug, but just typically, what was the process like?
Sure. Yeah, I think a lot of this is in flux right now, but I think, in sleep apnea, in the sleep apnea field, I think as providers, we always had like overweight and obesity certainly on our mind, and all the guidelines say like, if they, recommend like weight optimization. And I also like the term of optimization rather than like weight loss, to also kind of, keep it more neutral, and, trying to also like, approach my patients, like asking them like, how has your weight been changing? Have you tried losing weight? And, kind of trying to have a very careful conversation about that, to see like where they are in their journey, and, trying to see if they need help. And, I think most patients appreciate that usually, and, some patients are not ready, and that is fine too. In the past, it basically has been, primarily focused on lifestyle intervention on one side. And for that, we do have like a weight management program where we can refer patients to, but oftentimes they're often booked out. Coverage of the services may, for some patients, depending on the insurance, not be available. And then for the more severe cases, yeah, we've been using bariatric surgery, but bariatric surgery is, can be very helpful for a lot of patients, but it is a big intervention, and can come with a lot of potential side effects or complications and risks and so forth. So, I think it has been like a difficult decision for a lot of patients. But I think as sleep providers in the past, we usually counseled patients about the importance of diet and exercise, but then kind of like stopped there and kind of left it up to other providers to basically like talk more about like weight loss medications or the bariatric surgery, usually like in the setting of like a weight management clinic if possible. And so I think now we kind of have to rethink this, but we can get to that like later.
Right. And we'll come back to it. Tracy, do you want to add anything there? Because this is something I think you guys probably hear a lot about too. not from the OSA perspective, at least from the obesity perspective, trying to interact with the patients or suggesting, sort of late weight loss to improve their other cardiometabolic symptoms?
Yeah, I mean, one of the struggles we hear from our community about often is even finding a provider that is trained and qualified to be able to help them. So one of the things that we try to do is, help patients find providers in their area that know how to deliver evidence-based care and are knowledgeable enough to offer the spectrum of evidence-based treatment options. So that's kind of one area we support people with. On our website too, we educate about all the science-based, evidence-based treatment options as well. So we're trying to educate our membership and the public, as well as make that connection to the right provider to kind of initiate that step in the patient journey of like finding that right provider who knows how to deliver care.
Right, right. So thank you for that. And then one thing that I was very interested in, and this is like, again, something you alluded to that our community faces is, obesity was not considered a chronic disease until just very recently, a few years ago. And I believe your organization had a lot to do with behind that. So again, how recently was this recognized as a disease? And in your opinion, has this changed the way obesity medicine is practiced? Now, OSA is always, sort of the term they would use as a condition, but I think if you look at the CDC definition, OSA pretty much also starts to fall under the definition of a chronic disease. So just wanted to get some thoughts, your thoughts on this.
Yeah, obesity was officially recognized as a chronic disease in 2013 by the American Medical Association. So over the last 12 years, there's been increasing awareness and understanding of the science behind obesity, the physiologic, the biologic pathways of obesity, making trying to really connect the science with just modern understanding of what it actually is and what it isn't. I think that obesity has an additional layer of complexity when it comes to the bias that society has around body shapes and sizes and what the ideal is. So we kind of have a little there. I think there is additional complexity there, just across the board. We have seen a tremendous improvement in the general understanding around obesity as a disease, especially over the last few years with the entrance of the newer generation of the medications that are, highly safe and effective for many, many people that have tried them and taken them. So we do recognize that the new innovations and some of these new treatments have been a positive influence on the understanding of obesity as a disease and the need for access to care and treatment.
That's great. And I think we can certainly learn a lot from the obesity, field and what's happened there. On that note, when you said innovation, FDA just as of December approved a new medication, and this is a prescription medication for tirzepatide for sleep apnea. It's also known as Zepbound. For weight loss. So now, the way I see it, this is another tool in the toolbox for physicians, right, to treat OSA. And to Chris's point earlier, which again, it's a little complex, but let's explore a bit about that. So, Chris, now that you have this medication, and how do we use that in the sleep practice? Because we don't really, as I believe, we don't really have a guidelines yet in place, and also in conjunction with other therapies. So, and then how do sleep providers, do they prescribe this or they refer them to, again, weight management specialists? How is the practice going to change? And then again, my curiosity was, can primary care physicians start to prescribe this? And then, so how do you see the sort of the scenario playing out with this?
Good questions, but there's a lot to unpack there.
Yes.
I think to your first comment, yeah, I think, as a sleep field, we're still trying to figure out right now, like, how are we using now these powerful tools that suddenly we have at our disposal? In terms of guidelines, the obesity, the guidelines for how to manage obesity in the setting of sleep apnea are currently being worked or revised, for example, for the ATS. So there might be some guidance, but I think part of it is still, a lot of it is still going to be expert opinion about how to best include this. To be honest, when I first saw like the studies about tirzepatide or even like semaglutide, where patients been losing like 15% of body weight or so, and now with tirzepatide about 20% on average, which not everybody's the same, but on average this is big loss in body weight there. And now with tirzepatide, on top of that, we had like recently this large trial, Zepbound OSA, which was led by my mentor, Dr. Malhotra, which had demonstrated that not only like do people like lose 50% of body weight if they have comorbid obesity and sleep apnea, but also their sleep apnea over a year improves by about 50%. And then that led to like huge improvements in blood pressure, markers of cardiovascular risk, even symptoms related to the sleep apnea. And so when I first saw this, I was like, okay, wow, like, this is what we basically probably have to do like now first line for patients. And for me, like, I always use like that analogy that, if, cardiologists, their main goal is to treat like prevent heart attacks and strokes. And, if imagine like a cardiologist who says like, no, I'm not going to use like statins because I'm not an endocrinologist. Like cholesterol is not my thing. No, like they had to learn, they had to take this on in order to improve like the cardiovascular health for their patients. And so personally, my feeling is that, as sleep providers, if we eventually we have to get comfortable with prescribing these new, powerful, effective, safe medications in order to help our patients with their sleep apnea. Personally, I think there's, another level where, a lot of patients with sleep apnea, they come to us for symptoms, but a lot of patients also come because they're worried about cardiovascular risk. And without going into too much detail, the link between sleep apnea and cardiovascular risk there's still a question mark for a lot of these things. We think that like treating the sleep apnea often helps prevent heart attacks and strokes or so, but if you look at large clinical trials like SAFE trial or so, it hasn't actually panned out. And there's a lot of debate in the field why this may be. I still think that sleep apnea probably carries some risk for cardiovascular disease, but for obesity, I think it has been pretty clearly established that that is a major risk factor for a lot of like these things that we're otherwise trying to hope to also improve with treating the sleep apnea. So for me, it's a very clear thing that yes, we have to use these medications. We just have to try to figure out how to use them, when to use them. Like, do we use them first line? Do we use them in conjunction with therapies for sleep apnea? Do we use them afterwards or something like that? And I can comment more on like, what we asked patients actually recently, seeing what they would like to do. We asked providers how they would like to approach it. But on the other side, talking with a lot of my colleagues are not comfortable right now prescribing these medications, which initially was a bit of a surprise to me. But I think, I also understand where they are coming from. Like, one part of the story I think is probably that, we have been very well trained to prescribe CPAP machines, oral appliances, talk about surgery and all those things. We're not really trained to kind of like, how do you inject like a medication? I think this is, it's not that hard. You can learn this. I learned it myself. But I think there's like, this barrier right now that, people haven't had this training, they haven't had the experience. The other part, I think, which is also a valid point, is that, people say like, well, in Surmount OSA, this was like an efficacy study, meaning that, it was under optimal conditions, right? Like all these patients, they had like, dietitian counseling and like, really like focus on healthy lifestyle and so forth. So if I just prescribe this in my practice where I might not have access to all these things, is this still going to work? Is this still going to help patients? And so I think that's another question, like, how this is actually going to pan out in clinical practice. And, we're looking at some ways of potentially studying that.
So clearly there's a need for more education when it comes to physicians and of course, even the patients, because I think one of the concerns is that are people quickly going to say, I don't want to use my CPAP. There's this new medication. I would rather take this. But again, what is that indicated for? I mean, again, very based on the studies, it is for the obese patients. You have to fit the certain category. And then, you've been on CPAP for a long time. Would you just, stop your CPAP? So I think there are a lot of unanswered questions. It's still a very complex landscape. But the exciting news is we actually have a medication now, again, like it is a powerful tool in the toolbox. It's all a matter of which patient who benefits from this and how do we work through some of that. I do just want to clarify for the viewers, when you said ATS, it refers to American Thoracic Society. It's a professional organization that are coming up with guidelines. And also regarding the Surmount OSA, I will add a link later to our video. We did interview, it was me and the co-founder of the Italian Association for Sleep Apnea. I had interviewed Dr. Atul Malhotra a few months ago. So there will be a link to that, which really Dr. Malhotra goes through the results of the Surmount OSA, and the results looked great. So Tracy, just coming back to, you, how have the anti-obesity drugs like changed the landscape of your community, right? I mean, again, you said you're already on sort of the second generation of these medications. And did you notice there was that kind of same hesitancy with the physicians in the beginning, where they're giving, using these treatments? And then adding this new indication of sleep apnea for tirzepatide, which was only for treating obesity and now has the sleep apnea. Will this mean for the physicians now treating obesity? So in a way, we're looking at it from the other angle, coming from the obesity community.
Yeah, I mean, I think that the landscape for OAC has changed in a few different ways. I think it's changed, and I'll briefly touch on each. I think from the patient perspective, from the provider perspective, and then from like the policy public perspective. From the patient perspective, these new innovations, these new medications have brought hope to our community. Our community has been living with a chronic disease for many years. And the earlier treatments didn't have as high of efficacy as these newer treatments do, right? So that kind of perpetuated a lot of the self-shame and blame that people were on the hook, an individual was on the hook for trying to manage their own chronic disease. We don't do that in other diseases, right? We don't put people on the hook for managing their cancer. There's a very clear patient journey and treatment plan that's available to someone. So I think a lot of hope has been brought to our community, and now people are growing in awareness and very interested to try new treatments for the first time. Now that leads to providers. So patients are starting to go to providers. Providers are learning more about the topic, really all types of providers. In the earlier days of the newer generation of these, this newer generation of meds, the specialty physicians were the ones that were getting into it, like the endocrinologists. Mm-hmm. They were kind of the first ones to come on board because they were familiar with the class due to the diabetes indications, right? So a lot of people, endocrinologists were kind of the forward first provider group, and then we look to the cardiologists, and now sleep physicians, as well as then the primary care community is still, I think there's a lot of mix. There's some in the primary care community that are trying to learn more. The interest in learning about obesity medicine is growing. If you look at the obesity medicine fellowship program, there's almost like a J-curve spike of the number of certifications of physicians that are getting board certified in obesity medicine, because it is a very kind of hot topic in medicine right now. So that's all a good sign for the patient community that more providers are trained and qualified. And then from a policy landscape, coverage, we have seen an increase in coverage for these types of medications, and that is a good sign. However, we do have a number of policy barriers that we are still trying to address, and I know we'll get into that in a little bit. But so it's we kind of move a couple steps forward, but we still have a long way to go from kind of a policy and coverage perspective.
Let's get into that in a bit because I do have some questions. But Chris, when to use tirzepatide in sleep practice and how to use it, and I just want to make a caveat. We're already talking about how to use it. I think the coverage doesn't start till 2026, but I think Tracy, you can explain a bit of that when we get into the sort of the policy conversation. But again, Chris, just thinking ahead, when to start using this in sleep practice, how to use it, and then I think you did get into this a bit with the first line and the second line, alone or in combination with CPAP. So I think let's continue that conversation from the beginning and just give us a little more clarity on that. And this is probably helpful even for the sleep physicians who are thinking about this.
I mean, just to be clear about this, what I'm going to say next is like really just basically my personal opinion. And so, but I think my view is that for patients with comorbid obesity and sleep apnea who are not like at immediate risk of a car accident or losing their job because of their sleepiness or things like that, I personally believe it probably would be reasonable to offer them, if they're interested, the tirzepatide and kind of like see like where things are going, to kind of really focus like the effort, their mental effort, the resources in terms of like cost coverage, really on getting this medication and really focusing on this for a year. And there's a chance that like their sleep apnea is going to get away and that they reap a lot of other benefits in addition to that too. That said, I think if someone has like a lot of symptoms or feels like they need like quick relief, then I think it would be reasonable to treat both with tirzepatide and a CPAP, for example, or in a combination. But I think a lot of this is really right now going to depend on patient preference. In my practice, again, I'm seeing like primarily patients who have failed standard therapies. So for me, like oftentimes this is like kind of the next step before we now, I also build like a program for like hypoglossal nerve stimulation, which is like a surgical treatment for sleep apnea. I think for some patients that also works like really well or so. But I think for the last 6 months or so, oftentimes we do take a step back with my patients and kind of take a look. Okay, should we maybe like first try to work on obesity and see like how much that can help with your sleep apnea? Is then there's still like a much sleep apnea left that we feel like is affecting your life or your potential health? Then let's kind of like revisit that. And in those patients, then often I find that it may then again more the surgery might actually be more effective like afterwards. So I think, but again, a lot of other providers right now, I think simply don't use it yet. And I think that's where also like that FDA label is going to make a real difference, because on one side, it seems like, why is there now a new label from the FDA? It was already approved for use of obesity basically, but now we're saying, okay, it's approved for OSA with obesity. And so I think, to some degree, it's kind of a nudge that, we as sleep providers, if we're treating sleep apnea, we really should consider this and not just say like, okay, well, maybe like the primary care doctor can consider this, or maybe like, the obesity specialist can consider this. I think the onus is on us to kind of figure out how to implement this in our care model.
Yeah, no, thanks for that, Chris. So Tracy, let's come back to you and maybe you can unpack this for us a little bit, because what had happened was the FDA had approved the medication. This was, I believe, on December 10th, not December 10th, December 20th. But before then, a week, 10 days before, CMS came up with a proposed rule making. Maybe you can even discuss what that means for our general audience. Basically saying that Medicare and Medicaid would cover this medication in 2026. So this is before even the FDA had approved, which is kind of, I thought, was unusual. We don't see that often. So a couple things that came out of the proposed rule making was, one, that they were going to cover all anti-obesity medications, which was great for your community. And two, they said previously it was approved in conjunction if somebody had a chronic condition of diabetes or risk for cardiovascular disease, it will be covered. Now they're saying, let's just add sleep apnea into that too. So explain sort of to us about that process and what it means. And again, what do you think of this coverage for tirzepatide moving forward. We still have a year to, again, figure all of this thing out. But the good news is it will be covered. That was, again, my sort of takeaway. So explain this process and with regard to the rulemaking and how this whole thing sort of unpacked over the last few weeks.
Yeah, I'll actually start even one step earlier in regards to, the new FDA indication for OSA and obesity. So when the most recent indication for obesity and cardiovascular disease risk reduction came out back in March of 2024, CMS issued Medicare Part D coverage guidance. And what they said was in instances when an obesity medication receives approval for an additional medically accepted indication during the contract year, Part D sponsors may include such drugs on their current Part D formularies as they can be covered under Part D for that use. So these drugs will be added to the formulary file at the next available opportunity. And then they go on to say that, Medicare Part D drug plans can use utilization management tools like prior authorization or step therapy or quantity limits, strategies like that. But that the Part D plan can and should make this new approval and coverage available at the next the next available opportunity. So they don't even have to wait until the next plan year under Medicare Part D to start the coverage. And that is actually what I expect in 2025, is that some Medicare Part D plans will start covering tirzepatide for the OSA indication. And that is, and if they are not, one of the roles that OAC does in our advocacy is like, we will reach out to CMS and say, we're hearing from our community and people are having a hard time getting their coverage. So we would love to hear from members of your community, and we will be listening to members of our community who are Medicare beneficiaries, right? So that's under Medicare Part D, that's the guidance there. Now, when you mentioned the proposed rule actually that essentially is proposing coverage for obesity medications more broadly for obesity itself and the other approved indications. Now, that guidance actually calls out OSA, and they specifically say they already consider OSA covered in the proposed rule language. So that's a huge benefit to the OSA community. So in that event, this proposed rule specifically calls out that OSA should have coverage under Medicare. And that shouldn't have to wait until 2026. We should be seeing it in 2025. And if your members and my members of my community are not seeing that, we will make CMS aware and find out what the next steps need to take place, which typically is CMS reaching out to the Medicare Part D plans and say, hey, why aren't you covering this? And getting that essentially holding the insurance plan's feet to the fire to say you should be providing this coverage.
So thank you for that, because that was a little hard to read and kind of wrap our head around that. But you made it really clear. So it should be covered under Medicare Part B. And if it's not, the patients should be reaching out to us, and we can be then reaching out to CMS and say what is happening. Yes.
Yeah. So for the Medicare Part D, yeah. However, I will just note that if for your members that are, have different, if you're not under Medicare, right? If you're under Medicaid, we would Medicaid typically follows FDA approval coverage. Medicaid plans do. Now, when we get into the private insurance plans, the Affordable Care Act exchange marketplace plans, or employer sponsored health coverage, that gets a little bit more variable. So what we suggest patients do is submit for the prescription, and if denied, initiate the appeals process. So start an appeals process, provide that documentation of the FDA approval, and work with your provider, your clinician, to go through those steps. It's a pain. It takes time, but that is how we are supporting members of our community and what we recommend from the process perspective.
No, thank you so much for that. And I think if we have any questions, we'll certainly reach out to you for your support as well. Chris, do you want to add anything regarding the access to these medications based on what, again, Tracy has said here?
Yeah, actually, this is great. I'm learning a lot here right now.
Yeah.
I had about I think 15, 20 patients or so in the last year where we tried to start them on tirzepatide, and I think about half of them or so got approved. So, there's certainly some insurances seem to kind of be okay with it. And then the other half, however, unfortunately, pretty much denied it. And I just started now, also encouraged by the FDA approval. I just last week I wrote my first appeal letter now, kind of saying this is severe sleep apnea, exactly approved for this, not much other options. So please approve this. So I hope this is going to play out well, and if not, I'll let you know, Tracy.
No, it's great. All right, let's move on a bit more, because something we brought up earlier, we definitely need more increased awareness and education for both providers and patients. And again, Chris, do you want to talk a bit more about actually, let me say this. Let's reiterate that fact. I think as, again, ASAP, how can we help here? Do you want to suggest something? Clearly, there's a lot more education. I mean, even starting with this webinar, we're going to put this out, and then there'll be a lot of questions. But again, let's just reiterate some of the things that we've discussed before. What do providers need to know? What do patients need to know about this? Let's, again, tackle it from that angle, and how we can, as a patient organization, support in some of this information. So Chris, you go first, and then maybe Tracy can add to that too.
Yeah, I think the most important thing is to kind of have a discussion about it. And I think that's what you're really helping right now to do, bringing people together and kind of talking about these things, getting different perspectives. It doesn't help if patients want it, providers want it, but it's medication is so expensive that it's gonna break the bank. So you have to really have all the stakeholders involved in order to kind of figure out how to do this in a way that is beneficial really for everyone. And so yeah, I think this today is a great start, and we have discussions in our clinic, and I think talking with patients and bringing everyone together is the important thing to do. And I'm sure the next conferences we're going to go to, everything is going to be about this and figuring out how to do it.
Absolutely. Tracy.
Yeah, educating our patient population. So, providing, written resources, visual resources, different campaigns, right? Campaigns to get the word out. I think what I really like what Chris said about bringing stakeholders together. So, OAC, we collaborate a lot with the physician and the research community associations, societies, to amplify our efforts. We also participate in coalitions. So, in obesity, we have the Obesity Care Advocacy Network, trying to raise awareness to obesity at the national level. And, Monica, I encourage you, invite you to, look into joining OCAN. We have a lot of the renal groups, diabetes, heart groups, liver groups, things like that. So we're all coming together with shared priorities and a stronger messaging when we're all kind of using the same, key highlights and talking points, when we're all talking about the issue in the same way. So I think bringing groups together and collaborating in that way is a way to kind of amplify that education and public awareness. And then, I think getting the science out? Like how do you communicate the science in an easy to understand and digestible way? That's one thing that, OAC that we work hard at doing. And I think that you all at ASAP do as well, is to make it simple and easy to understand. And one of the goals there is to help patients, providers, and the policymakers catch up with the science, right? We want everybody to know about these amazing innovations and advances and how they can help us in all these different ways. So I just echo that. How can we come together more as a community to improve the lives of the patients that we serve?
No, I completely agree with you on that. And I think right now we need to get our physicians community on board with some guidelines and things. Hopefully we can look forward to that soon. Chris, do you want to take a couple minutes and then also talk about the survey that you are doing, the pro-con survey, and just kind of mention that to our audience?
Sure. I think that's actually a perfect segue. And that was maybe like one more thought I had, like, part of it is like having people kind of discuss with each other. But then I think part of it is also just really learning, like, what do people actually want from the different stakeholder groups? What are their concerns? What are their questions and so forth? And, we've been trying to learn more about this by creating like this survey, which we call pro-con, which really kind of is all about like, as part of that survey, which is completely anonymous and which we had sent out to like our patients here at UCSD and then also to the providers here at UCSD, we basically asked them like, how to, first we educated them a little bit about these new medications, tirzepatide, this is what it means, and, this is what it involves, and that's what you can expect. This is CPAP, which we commonly use. This is how it works, and this is what you can expect. Kind of make sure that everybody, has a reasonable understanding. And we had like some patients and providers review it to make sure that it's like, unbiased to the extent possible. And then we asked them, like, if you were a patient, you're newly diagnosed, and you're living both with obesity and sleep apnea, how acceptable would this treatment be for you? How acceptable would that treatment be for you? And so, interestingly, like, most patients found that both CPAP and tirzepatide would be acceptable, highly acceptable to them. But more patients found tirzepatide acceptable, compared to like when we asked for providers, they also kind of found both things acceptable, but like leaned more towards CPAP. Also, when we put it head to head, when we said like, if there was evidence that, both therapies are equally good for, your condition, which one would you prefer? There was like about 2/3 of patients leaned towards like the tirzepatide, whereas like, providers, it was exactly the opposite way. And then also like, I think one thing that I also quite found surprising is, because a lot of providers, I think like, let's just do both, let's treat the obesity, let's treat the sleep apnea both at the same time. But again, there's like, now you have twice the effort, twice the cost and so forth. And so interestingly there, like, I think still about 40% of patients said like, yeah, that's fine with me. But, 60 or 70% of providers said, yeah, that's fine with me. So I think there is like also like a bit of a divergence where like, patients say like, if I don't really have to do both, I'd rather not. So, but also right now this is still like UCSD sample. So right now we're in the process of trying to really get like more of a national representative sample, to kind of really see, what people think. And then I think this can be like highly informative in order then to say like, okay, what do we need to, what evidence do we need in order to kind of inform these discussions, to inform like the guidelines and inform our practice ultimately.
No, that's great. And then we're happy to share any information on the survey that you have, with our audiences. We'll post that on our website. So just finally, just want to make clarity based on what you said, Chris, that allowing patients to or using this drug can reduce the severity of some of the symptoms. Maybe so the management strategies might differ once they lose, the weight, and then to manage their OSA. But some patients might think that the OSA may go away. I mean, are we sure it goes away? Because some research has shown, even with the bariatric surgery, that OSA may not go away. And again, it depends, right, what the root cause of that OSA is. Do you want to just quickly expand on that?
Yeah, sure. So definitely, I think in general, like if someone has like both obesity and sleep apnea, and we kind of go down that pathway of, okay, we're treating now the obesity first, I think at some point we should have like a a follow-up where we say, okay, now, if you still have symptoms or if there's still concerns about sleep apnea, we should do a retesting. We shouldn't just assume that it goes away because even Surmount OSA, I think about on average sleep apnea improved by about 55% or so. I think in about 40%, sleep apnea went away depending on how you kind of define it. So which also means like, about, half the people still had some sleep apnea left. And so you have then to kind of decide, how are we managing this residual sleep apnea? And for some patients at this point, maybe like healthy lifestyle measures might be enough, like, the avoiding sleeping on your back, avoiding alcohol close to bedtime, avoid drowsy driving, make sure you get enough sleep. But for a lot of other patients, there may still be a need to use like other therapies like oral appliance or then, surgery or so. And, it hasn't been studied, but, for some patients, maybe like even the CPAP may work now better because now like, they don't have as much sleep apnea anymore, so they don't need as much pressure, maybe more comfortable and so forth. So I think you definitely can't just like, treat it and then kind of leave it there. I think it needs close follow-up, and even like for good management of the weight loss medication, you need like close follow-up and monitoring and so forth. Maybe let me stop there.
Yeah, great. No, great to know. Any final thoughts from you, Tracy, before we wrap up?
I would just say that I'm really excited about our patient communities having more access to care in this way, and looking forward to the opportunities to collaborate with you, Monica, on ensuring people can get what they need.
Absolutely. And Chris, any final thought?
No, I just thanks again for bringing us all together and starting the conversation. And again, I think it's a really exciting time right now. And so looking forward to see where this all is going.
No, certainly an exciting time for the OSA community, especially because I think there's a lot of innovation happening in the space. We certainly need to see more treatment options, more tools in the toolbox for physicians. And I think definitely it's going to be a different year with this medication and hopefully others, in the pipeline. So in just closing, I want to thank you both for your insights and engaging in this conversation today. It was pretty exciting. This program is supported by Eli Lilly and Company. And to our audience members, I do want to say that if you want to share your stories related to your experience with obesity and sleep apnea, please feel free to email us at info@apneapartners.org. I also encourage you to sign up for a newsletter so you can stay connected with us. You can follow us on social media. We're on Facebook, LinkedIn, Twitter, X, and Instagram, as well as on YouTube. We will be making, since we're recording this webinar today, and we will make this available to you soon on YouTube, where you can check out all our previous episodes. So again, thank you both for your time today.
Thank you.